Welcome back to Doc Talks, Season 4, Episode 12. And we have our special guests tonight, Kat and Bob, with us. And we have a lot of our Doc Talks family with us tonight. And Dr. Tennant, I know you have a very busy schedule this evening and a lot to announce. So I'm looking forward to what you have to say. And welcome also, Dr. Ibsen. Thank you all so much.
Thank you very much, Jamie. This is an exciting meeting. A lot of you, of course, are aware that the issue of the Epstein-Barr virus is now out of the bag. It's out of the closet, and rightfully should be. I want to start this session by reading you a short letter that I received 2 or 3 days ago. It's from a woman who has adhesive arachnoiditis, and she writes me this email, and it says, "I just got my EBV results, and they are over the top. They are over 750. I'm terrified. I'm afraid my life is over." Okay, now we're going to dissect this letter for just a moment and talk about what this means. First off, let's talk about, she has adhesive arachnoiditis, and now she's got a very high Epstein-Barr test, okay? Now, we now are quite aware that over 90% of people who develop adhesive arachnoiditis have Epstein-Barr of at least, that's one factor. May not be the cause, but it's a factor, meaning it's one of some other causes. Okay, so we're going to start with that. And incidentally, before you have Epstein-Barr virus give you adhesive arachnoiditis, you're going to go through a whole series of steps. You're going to start off with fibromyalgia or migraine headaches or irritable bowel or burning mouth or pudendal neuropathy, burning feet. Then you're going to get some discs that are going to slip. You might get some CFS leaks. You might have a Tarloff cyst. And the last thing that's going to happen is that your arachnoid membrane and your cauda-equina nerves are going to become inflamed due to autoimmunity, and they're going to glue together. Now, that may take years for that pathway to occur. Years. It can happen in a few weeks or months, but that's very rare. It normally takes some years to go from step one down to where you develop adhesive arachnoiditis, okay? So this woman already has a lot of other conditions besides adhesive arachnoiditis. And she's gotten some of the publicity, so she's had her doctor take a test. Okay, now what does 750 mean? Okay, now there are 2 major laboratories in the country, Quest and LabCorp, but there are some other regional labs. They're all good. And to their credit, the laboratory science field has developed very accurate tests for the Epstein-Barr virus, both for the chronic user plus for infectious mononucleosis, which is caused by Epstein-Barr virus, and for cancer, but we're interested in only about 3 out of about 8 tests that are available to the physician. Now, let me stop right here for just a minute. I'm not going to kid anybody. This is a little complex, okay? I'm afraid this is not just one point, one action. This is going to take some study. As a matter of fact, physicians are going to have to study this, and I'm going about tonight's program in a special way because I've already starting to talk to some of you out there. We're going to need some educators. We're going to need some people who can educate people on what I call the alphabet soup, EDS, EBV, AA. We need some lay educators. Those of you who are interested, I'd like to know about it. There's already some preliminary plans for later this year, early next year, to have a couple of seminars for people who want to become educators in all of this. It's just complex enough. I'm afraid you can get part of it out of these podcasts. You can get part of what you got to know out of our bulletins. You can get part of it out of the website, and you can get part of it out of the books. I don't know whether that's going to be enough or whether we're going to have some classroom instruction for people to learn how to do this. And given the slow adoption by universities towards anything these days, medical students won't learn about this for years. So right now, we've uncovered a great scientific breakthrough. Okay? Now, the lady who's terrified about her 750 level, she really ought to thank the good Lord that she found out about it. Why? If she's over 750, she's going to end up bedbound, her life's going to be shortened, and she's going to deteriorate into almost a vegetable if she doesn't take action. So she's actually had a blessing. Now, let's talk about what the 750 does mean. The two laboratories, the major ones, I think one of them has their upper levels of these antibodies at 750, and one is at 600. So if you do go above the 750 or the 600, that's the upper level of the laboratory. The laboratory can't test higher than that. In other words, her level may not be 750. It may really be 1750. We don't know. We just know that it's way above the ability of the laboratory to test. In other words, he's got a problem. There's no two ways about it. Now, let's go a little further with this. She didn't tell me what antibody it was. She just said she had 750. Now, here's where the complexity starts to come in. And I wish it wasn't this way. In order to determine whether the virus has reactivated, whether it's causing autoimmunity, whether it's causing you to have pain and deterioration, at this point, there's about 3 tests we need, okay? And there's about 8 available to physicians, but they're for different purposes. But there are 3 that you need to have. And so she just said she had one of them at 750. I'm not sure which one that was. It's one of 2. So we don't even know which one it was, whether it's the worst one or the best one. So we don't know what 750 means. You got to have all 3 tests. And I'm here daily. I'm having somebody ask me to tell them what their tests mean, but they only have maybe one of the 3, 2 of the 3. If you don't have all 3, it's kind of like trying to play badminton with your one arm behind you. You can't do it. You got to have all 3 tests. So that's one of the first things, unfortunately, that people are going to have to need. You need all 3 tests. Secondly, she's terrified. Well, I don't know that she needs to be terrified. She does need to be concerned, but not so terrified she can't take action. She's going to have to take some action because she's going to have to find out, is the virus active? Does she have autoimmunity? What's it doing to her? Now, all these things can be determined. And so she, in some ways, is lucky. She's found out about it before she gets a cancer, before she gets adhesive arachnoiditis, before she gets pudendal neuropathy or gets some terrible condition. So she's actually diagnosed her case at a time you can intervene to where she's not going to deteriorate. Now, let me stop right here for a minute. Somebody may want to disagree with me, but all of my studies and clinical experience tell me one thing. The Epstein-Barr virus, autoimmunity and reactivation, is responsible, it's the main thing that causes you to deteriorate if you have intractable pain or you have adhesive arachnoiditis and maybe CRPS or some other terrible diseases. In other words, if you don't put some controls on this virus, on this activated virus, you will deteriorate. And in our studies, that looks like the major factor that people who are seriously deteriorating, they've got to do something. They've got to get that viral test and start trying to do some intervention. So with that, I don't want to cover a lot of the treatments and stuff, except I want to say a couple of things about treatments. There are 3 elements to the treating the Epstein-Barr. One element's quite easy on how you stop it from activating more. And you do that with things like plain old vitamin C and zinc and selenium and lysine and quercetin and turmeric. There's a lot of things that'll help on that. And now, if you have what's called early reactivation, you may have to take steroids and an antiviral agent. Now, there's another thing about this that I have to bring up. We wondered for years why we couldn't cure things like lupus or rheumatoid arthritis or type 2, type 1 diabetes, for example. And we now know that a lot of that is caused by the formation of autoantibodies. Now, an autoantibody, I've talked about this before, keep it simple. This is when the virus causes your body to make an antibody that starts attacking your own tissues. Okay? And we don't know how to get rid of that. We can suppress it, we can keep your tissues protected. But once you develop the autoantibodies, at this time, we don't have specific treatments for them. We do have, for rheumatoid arthritis and lupus, some of the things they call biologics, which try to reduce the autoantibodies. And then we're having some luck with that. And we're even having some people with adhesive arachnoiditis take things like methotrexate and some of the drugs that we use for rheumatoid arthritis, and are having some success. Okay? Now, I want to point out something to you on how this virus works. Now, incidentally, one other thing about this virus. Early on, when I started studying this many years ago, it was very confusing. I'd take somebody's blood that have elevated cytomegalovirus test, herpes 6, rubeola, and now we've got COVID, we've got Lyme, we've got mycoplasma, and I'd see where there were elevations of multiple viruses and some bacteria. And I didn't know what to make out of it, but as time went on, we figured out that the Epstein-Barr virus is the dominant virus. These others are sort of enhancers or tag-alongs, but they make the Epstein-Barr more potent. COVID probably does the same thing. I can't tell you whether long COVID is related to the Epstein-Barr virus or not, but I wouldn't be surprised if we find out that's the case. Okay, now I'm going to show you a picture here. Now this is a picture of the bloodstream. I hope, Danny, can you see this? You see all that red on there?
Yes, sir.
Okay, you got it? Now, and you see the veins, that's the blue ones. Now I'm going to turn over a page and show you this next picture. This one here, I don't even see that or not. That is the lymph draining. Okay, what they call lymphatics. Now the lymphatics, the bloodstream will carry the virus to all these places. Now those blood vessels go to your tongue, bottom of your feet, your brain, your arachnoid membrane, your groin, goes everywhere. And you don't know where. When this virus decides to reactivate, the lymphocytes will carry it, gosh knows where. That's why some people one day will have pain in their knee, and the next day in their shoulder, and maybe the next day in their head, or the next day in their stomach. It's migratory. And that's because the blood will carry the reactivated virus to these different spots. Okay? And so that's why one person will start off with burning mouth, another person will start off with fibromyalgia, and then the chain reaction starts over time, and you can end up with adhesive arachnoiditis. So I just want you to know that that virus gets carried in the blood to hither, nither, and yon. And there's a lot of blood supply going into the spinal column, and that's why spinal diseases and intractable pain is so common with the virus. Okay. At any rate, we're going to cover treatment more thoroughly in some other sessions, but I do want to, let me just summarize for just a moment. I regret the complexity of this. This is something that needs to be taught in medical schools and internships and residencies. Doctors are going to have to figure out how to interpret these tests. Some of you patients are going to need to kind of step into the practitioner's shoes and try to learn as much about it as you can so we can educate other people. We are going to need some lay people, lay educators who understand the test results and understand which treatment element is going to be used for what level of blood there is or what the clinical condition is. As far as I'm concerned, this is no more difficult or no more complex than high blood pressure or diabetes or asthma. But if you're not shown or taught, it's a myth. It's Greek. You don't know. But you can certainly learn it. And I encourage all of you here that, since I know everybody who watches this podcast has an extra interest, those of you who want to be kind of lay educators who can take a phone call or counsel people, we certainly want to know about it. What I want to do next is totally shift gears for a minute. I've been running on this podcast for some time, and I have mentioned it in the past, but I want to mention the critical element of treatment for spinal canal inflammatory diseases, particularly adhesive arachnoiditis, relative to the legs and feet. Paralysis, foot drop, weakness, bedbound state primarily occurs because people become so weak in their legs and feet, they end up in bed, wheelchairs, can't walk, and that's usually the start then of deterioration overall. So I really want to emphasize that if you have cauda syndrome, you have multiple discs that are herniated, you've got adhesive arachnoiditis, you've got Tarloff cysts, you have to protect your legs and your feet. Now, what is the biologic or pathologic process here? The spinal canal is very small. It's only about the size of your thumb, your finger, okay? But inside that, you've got these nerves that are the size of threads almost. And they become entrapped by adhesions. That's why it's called adhesive arachnoiditis. You have these very fine nerves glued to the arachnoid. Now that gluing process does what we doctors like to call nerve entrapment, meaning it's caught up in adhesions and scars and fiber. If the nerve gets caught up there too long and unused, it atrophies and dies. That's called paralysis. That's called incontinence. That's called a foot drop. That's called inability to walk or stand. Okay? So how do we deal with that? Well, there's no one way, as you know. We advocate the potent anti-inflammatories, the corticosteroids, the peptides, all of these things, and now the Epstein-Barr virus treatment. But there's more to it than that. It is my personal opinion that physical measures are as important to keep from becoming paralyzed or develop foot drops with adhesive arachnoiditis as in all the medicine and nutrition you can take. Now, we're going to talk more about this. It turns out that if you can keep the electricity flowing through that entrapped nerve, the nerve does tend to grow. We even think some of the nerves grow around the scar, grow out of the entrapment. But you've got to work at it. You've got to work at it. Now, I'm going to show you something I've never shown on this podcast before, but there's a simple, cheap technique that I recommend for every single person who has adhesive arachnoiditis. And it's a very, very simple device, and it's called a foot rocker. A foot rocker. I'm going to show you mine. Here is a foot rocker. Okay. Now, it goes like this. Yeah. You're standing up now. You're rocking your foot. Like that. You can buy a foot rocker on internet for about 25 bucks. Okay. Now, what does a foot rocker do? That foot rocker has a motion that makes both the blood flow and lymph flow, and nerves, electricity, the electricity of the nerves move up and down all the way from your spinal column down to your big toe. If you have adhesive arachnoiditis, I know this may sound kind of funny. I think you ought to be rocking at least 3 or 4 times a day. Okay? You only got to do it for 30 seconds. Okay? If you're bedbound, I hope you can at least stand. If you can stand next to your bed, have your granddaughter or somebody buy you a foot rocker. Stand up and walk on your foot. If you're ever going to get out of that bed, this is probably your way out. Okay? But these foot rockers have a sort of a magical way of increasing your lymph flow, your blood flow, and your electrical flow. So the more electricity you can keep flowing up and down that leg, the more preventive it is to keep that nerve from being destroyed within the entrapment. Okay? And so, again, I also think the foot rocker, believe it or not, helps the nerves that go to the rectum and the sex organs and the bowel, because they're all coming out of that same entrapment, okay? Out of that same scar. So this foot rocker, to me, is an essential part of treatment. I would put this foot rocker right up there with treating your your Toradol and your Epstein-Barr treatment and your pain treatment. That's how important I feel these things are. Let's talk about some other things about legs and feet. A second thing I love, it's a little pricey, unfortunately, it's about $75, but you can get a small trampoline to walk on. Walking on a trampoline puts you off gravity, same principle. It's even a little more potent than a foot rocker. Keeps the lymph flow going, keeps the electricity flowing, keeps the blood flow going. Now, I don't want you out there bouncing around like the kids do. That's not the point. The point is just walking up and down, bouncing a little bit on the trampoline to keep the legs and the feet moving. Now, lastly, let's talk about walking. If you can still walk, whether it's with a walker or a cane, do it. And you want to think of walking like medicine. It's just like taking a pill. You've got to do it to keep the legs moving. Okay? Wiggling your toes, same thing. Anything from the waist down that you can massage, put in water and soak, wiggle, walk, or whatever, you do it. And I want to close this section out because we've got a very interesting guest coming on, and I know Dr. Ibsen's always got a great report for us. That is, everybody who's got adhesive arachnoiditis or one of the other spinal canal inflammatory diseases needs to have a daily, I'm talking every day now, routine to exercise your feet, your toes, and your legs. Okay? Enough said. All right. We're going to move on now. We have Mark. I see you're there. You got anything to say about leg work? I know you do a lot of
Yes, I
leg
do.
work.
Yeah,
I'm
yes,
not
I
talking
do.
about watching legs now. I'm talking about moving
Well,
legs.
you can watch my legs all you like. So I'm taking a walk because you reminded me to walk. So
There you go. What's a good doctor for except to nag you?
Right. You got to be a good student in this business. So the only other thing about I have for you, Dr. Tennant, is actually a question. There are these vibrating devices that are coming out. They're showing up on my Facebook feed, and they have a little bit of wiggle to them, sort of like one of those bongo boards. But I'm wondering, what do you know about that?
Oh, I like them.
Yeah.
You know, years ago, we used to get a handheld vibrator and we gave them to every patient and have them rub them, whatever. Then they disappeared from the market, and now I forget to talk about them. But they're excellent. These little vibrators, get one. There's nothing wrong with them at all. Some of these wraps that are warm, we didn't talk about foot soaks. I mean, in some cultures, they put herbs in the water and get great results with foot soaks. So these age-old remedies for foot and legs, great. Vibrators I really like because the vibrators step up the flow of electricity, lymph, blood, dynamite. Okay. Yeah.
Thank you.
I have yet to find a leg exercise or device that I don't like. Okay.
Me too.
All right. Now I know Kat and her husband are here somewhere. Jamie, do you want to bring them on?
Yes, sir. Yay.
There we go.
Here we go.
Kat and Bob, welcome. We're delighted you're here, and I know you've got an interesting story. Kat and Bob, can you tell us first off, I'm interested in knowing where you live and how did you end up in the situation you're in?
We live in San Antonio, Texas, and I was 15 when I got hurt, and then treatment ended up making it worse.
Want me to do it?
Yeah, I guess.
Okay. She's had bilateral total joint replacements on her face on the TMJ. She was one of the patients that used the Vitech implant, which is the Teflon and what was it? Ceramic. And the ceramic broke down, and the ceramic was grinding away at the bone. So she ended up dissolving.
I made auto antibodies.
Yeah, the end of her condyle all the way into her spinal cavity or head cavity. She now has titanium and high density polyethylene joints.
But I started with neck and upper back pain. And that's a lot of some of the stuff that you do. Degenerative disc disease, I lost curvature in my cervical. I have a S curvature in my upper back. I have a chronic compression fracture. I don't know what that is.
They were giving her so many steroids that her bones got brittle.
So how old were you when you got your first symptoms, either face or neck?
15. I was 15 years old. It was almost 41 years ago.
And how did it happen? Can you tell us exactly how it happened? And it's very unusual for a 15-year-old to have that kind of problem.
Car accidents.
Oh, it was a car accident.
And then 2 of them 8 days apart.
Did you end up
in the back, one from the front?
And did you end up in the hospital at that time?
I ended up in the emergency room. They just they didn't even x-ray, I don't think.
And then they sent you home?
Yeah.
Okay. Now, how did you get along? Were you eventually able to take off the neck brace or take medicine?
Yeah, I was able to take it off and did all the different treatments that were available at the time, chiropractic, PT.
Yeah, the dislocation never reduced.
Yeah.
So her jaw was completely out of joint all the time until she destroyed the condyle.
Okay. So did you get better in your 20s or?
Yeah, well, yes, I did. I was medicated, but now that it's less medication, it seems like there's more inflammation in my face and my back.
When you talk about less medication, you mean less than what?
Pain medication.
Are you one of the people who's been cut off your medicines?
Not all the way. I'm at 2.4% of what allowed me to function for normally. 20 years.
She was over 300 MME and now you're at what, 50?
I think it's 50 or
something like that.
And how long has that gone
on? Almost 8 years, I think.
You were at a proper dose 10 years ago, but you're not now. Is that it?
Yeah. And now I have Parkinson's.
You got Parkinson's, okay. But you're still not getting enough pain relief?
No.
What are your official medical diagnoses? What do they put down in your electronic medical record now?
Complicated.
They put it down as chronic pain, but there are several diagnoses for the spine and post-surgery, I think is what they would call the TMJ. They called it foreign body giant cell reaction. My body made antibodies to me, started to destroy the bone in my face. But then I developed more pain elsewhere.
Yeah, they abraded the joint and when they put the new joints in, but they never got all the material out of her body. So, and since it's a chemically neutral Teflon and ceramic, it does damage and the body responds, doesn't know what it's responding to.
Injections and stuff like that in my face just make it worse.
How many injections have you had in your face and your neck?
Well, my neck and my back, like 50 at least.
50 at least. And what did they tell you the injections were supposed to do?
Supposedly interrupt the pain cycle. And then it was going to fix itself. But at 19, I broke 2 vertebrae from the because I had so many steroids for 4 years while I was a teenager. Dose packs and shots and ganglion blocks and trigger point injections, joint injections. I mean,
Were these injections given to you by a orthopedist or a neurosurgeon?
neurosurgeon,
Neurosurgeon.
and then later pain doctor.
Do the injections give you any relief now?
No, I don't do them anymore because I have osteopenia now.
So what are you doing now for treatment?
The low dose opiate, it's methadone.
Low dose methadone. Do you do anything else for
That's
pain
a homeopathic dose.
Right.
Yeah, basically.
I've been doing PT exercises for about 41 years. I also use cognitive behavioral therapy and meditation, stuff like, and distraction most of all.
Well, she also has a pump, but that's
It helps just the upper back.
just the upper back. Yeah.
Now, what kind of a pump do you have?
It's it puts like bupivacaine in my upper back
And a catheter into the spinal fluid at the top
into
of her.
the spinal fluid.
Yeah, about what, C6?
No, I think it's T11 or something like that.
And what's in the pump?
Bupivacaine and a low dose hydromorphone.
Okay. What else do you do medically? Besides, you've got the methadone, you've got your pump with your hydromorphone and the bupivacaine.
We've been going through all the gabapentin type stuff. I'm taking Keppra right now. Doesn't do anything.
The original add-ons were for the tremor.
Yeah. And now I'm taking amantadine for the Parkinson's.
Right. Okay. Does that help your pain at all?
No.
Amantadine?
No.
No. Okay. What else are you taking besides your amantadine and your
Tizanidine.
Tizanidine? Are you taking a benzodiazepine now, or they took you off all of that?
They took me off of that.
Yep. No tapering, just gone.
Jesus.
If you could make
lost my mind. Yeah. Sorry.
No,
Can I jump in here?
Sure.
Dr. Tennant, multiple patients are now being weaned from their pain pump medications with the false belief that medication causes some sort of opioid-induced hyperalgesia.
Yeah.
This is criminal and malpractice to have a pain pump in and not have your pain managed. This is inexcusable. It's like having tires with no air in them. Sorry, that's enough for me.
Well, you've said it right there, though. Yeah. What let me come back more, because I do. You're getting ahead of me here on things I wanted to ask you. Okay. Because this is I'm mystified over some of this stuff. Now, Kat, have you been declared disabled, or are you able to work?
I'm disabled.
You get Social Security?
Yes.
Okay. And Bob, what do you do? I take it you work?
I'm retired. I retired early so that we could
He could
spend some time together.
Yeah.
I see. Okay. All right. And are you kids from San Antonio? Is that your home?
No, I'm from Texas. Different places in Texas. We moved down here for his job.
Yeah, I was doing real estate in Dallas, and moved here I'm actually a telecom engineer, and I was in the Marines. And anyhow, I came here. We met at Fujitsu.
We work together.
And yeah, that's where we started our relationship. We've been married, what, 27 years, something like
Yeah,
that?
something like that.
Well, good for you. Good for you. What are your plans going forward?
I don't know. That's what I'm at a loss. You know, I've been in pain management for a very long time because the stuff that's wrong with my back. Yes, they can do some surgeries on some of them, but the back surgeries, I would just end up with worse pain, I think.
Yeah.
And deep brain stimulation, after what they did to my jaw, I don't want them putting anything in my head.
Mm-hmm. I can't imagine you having any more surgeries or injections, but I'm sure that there are other opinions about that.
My pain doctor doesn't want to do any more injections because the osteopenia and the Botox didn't work. And
She's also a little bit of a flower child.
Mm-hmm.
Okay.
If you could just design your own treatment program, medical treatment program, what would it be?
Well, if I had even a little bit of the amount of medication I had before, I could PT again and probably be better. You know, I'm doing PT for Parkinson's, but I'm afraid to do it on my back now.
Yeah, once they replaced the joint, as soon as she got pain relief, she was highly functioning.
Mm-hmm. Great. Mark, what questions you have for her?
Okay, so you don't have osteopenia. You had hydromorphopenia. They're not giving you enough hydromorphone in your pump.
Well,
I'll accept that.
I'll accept that one.
And this is cruel and unusual, and this is beyond malpractice. This is punishment and torture. To go through the effort of a spinal cord, spinal pump, and then not put anything in it is, I would venture to say that there ought to be an injunction, like a legal thing saying you put this pump in me, and you guys better start putting the medication in it tomorrow. It's illegal, cruel, un-American, etc. And I'm sorry for my passion about this, but you're not the first person I've encountered with this, and it is.
Doctor that put it in is no longer doing service.
Right. Well, that leaves the rest of us, doesn't it?
Yeah.
You know, do you see anybody walking around with pacemakers getting taken out?
Mm.
All right, your cardiologist retires, they don't take your pacemaker out. What the actual fudge is this about?
Yeah.
And wow, I just want to scream, and I'm just too inarticulate when I'm this angry. So, but it is just awful.
Well, try raising your voice to a doctor when you're trying to get
and they don't like it.
They don't
Well,
like
they call the cops, don't they? Yeah.
Yeah. Well,
yeah.
I haven't had that happen.
They tag your file and you don't get it ever again.
Yeah. So one way to raise your voice with a doctor, since we're going there, and we're here. First of all, you can raise it to me anytime you want. Call me up and scream. The next thing is, doctors do not pay attention to threats from patients who are right in front of them, because they have the power to throw you out.
Yeah.
Okay. So that's not the way to do it. But the way to raise your voice with a doctor is with their medical board and with law enforcement. And essentially, granted, the doctor who put that thing in, this is classic medical unaccountability. Oh, some other doctor put that in, I'm not responsible to take care of it. Well, the medical system put it in, and those of us who are still in it are responsible to take care of people who are still in it.
Have you had anyone with a pump get more pain relief than just around where the catheter is?
Yeah.
Really?
Yeah, I mean, yeah, the pump is designed to the ideal thing about a pain pump is that it gives you a lot of medicine, which you can't become addicted to.
Yeah.
and you
Yeah.
can't share it with anyone else or divert it anywhere. So there's no reason to diminish the amount of medication you get in your pump, and it should be titrated to an effective level so that you could walk and get physical therapy. That's why they were invented. And this is criminal. I'm so sorry.
Mark, I agree with everything Mark has said, incidentally. I am truly mystified
Could,
that obviously, I want to ask you, Kat and Bob, anywhere along the line, did any of these doctors tell you what is their goal of treatment?
it's pain management now because I mean,
It's not relief.
Today,
It's pain mismanagement. Thank you.
well, yeah,
is management the same as relief?
no, it's not.
Try-
I mean, yes, it is relief. Even when I was on a higher dose, I wasn't pain free. I'm not asking to be pain free. I want the level down low enough that I can do something.
You can, yeah. It's hard to function when raising your blood pressure, even
Makes
even a
everything
couple
throb.
ticks makes everything throb.
Well, that's another good point. We have lots of pain patients who are being cut off, and they're hypertensive as can be, and they don't respond to blood pressure medicines. They respond to pain medicines. So we are causing strokes in patients with high blood pressure who are in agony, withdrawal, and pain, and we're not treating their pain. And the blood pressure isn't treated in any other way.
Yeah.
Another cruel aspect. I am so sorry.
Can could 8 years of pain from stress from pain cause Parkinson's?
I believe it does.
I'm going to say yes, because
Yes.
you've got it.
Yeah. Mm-hmm. Yeah, Parkinson's disease is a depletion of dopamine, and we've talked about that before, is that we think pain itself can deplete any number of these neurotransmitters like dopamine, and then the Epstein-Barr virus certainly can.
Yeah.
So your treatment or lack of treatment and development of Parkinsonism, frankly, is a story I've heard many times. Okay.
Sorry.
Yeah. Well, thank you, Kat and Bob. Our prayers are with you.
Thank you.
We will try to do whatever we can, but your story is a sad one. Mark, I'd like to shift over. I have been waiting to surprise you with a question here. One of the things that strikes me here, some cases have come up this week. We have something called a federal government. Why is it that the federal government has these agencies like DEA and FDA and CDC, but part of the governmental system is the medical schools and the universities?
Yep.
Years ago, it was customary in this country that universities would take difficult cases. They would evaluate them, send back a treatment plan to the practicing doctor. And do you know that was actually done in pain management back in the 80s and 90s of the last century? Now today, how does it happen we have total disconnect between these government agencies? And just like we just talked to Kate and Bob, I thought the goal was to relieve pain. What is anybody setting that as a goal anymore?
Well, it's a for-profit enterprise now because the use of the Chevron exemption allowed these agencies to operate without congressional authority. They're doing it because they can make money selling those
Spinal cord
positions,
stimulators,
spinal cord stimulators, pumps, and things like that. It's all about business.
Now, I agree with that, and I think there's other things involved as well. It's more about risk management than it is about patient care. So I had my bypass done at the great and powerful Cleveland Clinic, and they did a great job, and I love those people. It's like going to Oz for something. But they have such a juggernaut economically, as does the Mayo Clinic and some of these big institutions, that if Medicare and Medicaid all of a sudden defunded them, they would become a ghost. Cleveland would be a ghost town. And so there's this irrational fear of badness, like boogeymen, like undifferentiated badness, not specific bad acts, but people are so concerned about losing momentum in their program or losing funding somehow or losing a grant, that they begin to behave with hesitancy and fear, and they can't even put their finger on what they're afraid of. They're just afraid of something bad happening.
Kolodny,
I want to ask a question here. I wanted to ask a question here, which is,
You bet, Norm.
how are they being treated at their pharmacy? They go to get a prescription or bring in a prescription to their local pharmacist. How is that process working for them?
It's not working very well in a lot of parts of this country.
Are you asking Cat and Bob?
Yeah. Are you
Yeah.
feeling uncomfortable? Or the doctor, you get the pharmacist saying, I'm uncomfortable filling your prescription, or you're getting to your,
I've not had them decline my prescription yet,
Okay, that's good. That's rare, but it's good.
but I'm not above the limit. So
Mark,
What limit would that?
go ahead. Norm, go ahead.
Yeah, I said, therein lies the problem. What limit are we talking about? We're working on a false premise here when I hear the word, every time I hear the word morphine milligram equivalent, or MME,
yeah,
I know what we're headed for here. It's garbage, and I'll just leave it alone from there. Like I said, I'll let Mark take over from that point.
well, the
Well,
idea that they were,
Go ahead.
I'm sorry, the idea that they were trying to do risk management, all of the guys in the CDC, Dr. Kolodny and the crew from from PROP, what they were doing was their original assignment was risk reduction. They didn't want the hospitals and the doctors getting sued for making addicts. That was the story of the
except
moment.
addiction isn't just exposure.
So anyhow, that's what
Anyway.
started it all. They took over.
They know.
Yeah,
Yeah.
you got that.
Yeah.
All right.
No, that's okay. This is a public forum. You give your opinions. We want them.
If
We
you
want
guys
to
are
listen
supposed
to
to
you.
go over, I'm going to shut up.
But let me ask you this, since I think we'd all agree about this economic drive, risk management. So what are our patients who need pain medications? What's your advice right now for them?
You're asking me?
Yeah.
Okay.
Norm? Yeah. What do we tell them?
I want people to file complaints with adult protective services for their adult family members that are being mistreated. It's just as abusive as if somebody was beating them or starving them. Okay. So I think we have to broaden the number of agencies involved, which seems counterproductive. But you asked about government agencies and why can't they cooperate? Well, they didn't cooperate before 9/11, and they're in silos, and they're at different competitive goals. Going back to Kolodny, he went to the FDA and they said, no, we're not putting a limit on prescriptions. And so he went to the CDC, who's never taken care of pain before. They left their own lane and went into it because he had a pal there. And so it was connections, and it was just like about winning something. And I think what they won is a lot of money with their stock purchases
Yep.
of Suboxone. But
And the trial money.
but ultimately, these have to be litigated in other ways than with people who are terrified to harm someone, because what's really happening is, doctors don't want to go to jail, so they won't treat you.
Yeah. I use a phrase we call, when you mentioned Kolodny, it seems that the whole foundation is based on quackery. We use a phrase in when we write called turtles all the way down, which is from Bertrand Russell's, someone had made a comment about how the earth is supported. But again, we see that this whole idea of treatment is based on a quackery prop and from it massively affects patient care. And then we refer to this CDC standard, like Dr. Ibsen said, has no business in this whole thing. And Dr. Tennant comes back to you, says, well, what is happening here in medicine? You're not allowed to what you were trained to do back in the day, or what you want to call it, the old days or whatever. But we're not practicing medicine, we're practicing something entirely different.
Yes.
Yeah, whatever you want to call it, it's not good.
When
Right.
you send something into Adult Protective Services, how do you stay anonymous? Because then
You don't.
You don't?
So immediately your doctor says, well, I'm not treating you anymore.
Well, okay, good point. So you're going to say to Adult Protective Services, my spouse cat is being abused. I'm telling you that this patient is being abused. They've been tapered from their medications and there's abuse going on. Would you investigate it? And then let them find out who the doctor is, number one. If you file a complaint against the doctor with the medical board, and I have battled many of those and never one from a patient, by the way. If you file a complaint against the doctor and the medical board and the doctor retaliates you, that's the basis for another complaint. That's also unprofessional activity.
Yeah.
So we as patients fear badness too, because they have us wondering, could we do this or should we? Should we stand up for ourselves or should we, bribe somebody? And we're this close to a bribery economy, but at some point, you just have to say, okay, I'm going to take some consequences. They have screwed me up so badly that I've got to take some action. And then if they take action against you, that's unprofessional also. So I try to reassure my patients when I recommend they mention it to the medical board, and the medical board needs to be inundated with these complaints. They will ignore them and ignore them and ignore them and ignore them until there's so many they can't anymore.
Yeah.
I'm just thinking about 6 months with no pain meds.
Yeah. That'll be great.
The false premise here is the word addiction. I mean, addiction is a disease, a disease state. It's also we're pushing to a thing rather than dependency. We're misinterpreting medicine. Even if the person does become, quote, dependent or addicted, that's part of it. That's part of a clinical protocol that we have to put the patient through. But to then take addiction and put that inject that into medicine as criminality is what is dangerous here. These people aren't criminals; they're human.
That's right.
Human. I mean, I see two people who are human that are suffering, that need treatment, and I'm going to sit here and worry about addiction.
Yeah.
Come on.
Very good.
Yeah, that's well said. Very well said. Yeah, this fear of addiction is a straw dog. It's just an excuse. And we're ready to wrap it up here tonight.
Yeah.
We want to continue on.
I'm sorry,
this discussion.
Thank you.
I'd ask everybody here, where do we go from here? And we want to keep asking that because people are still suffering, and in some parts of the country, it's just tragic. It just mystifies you how we're treating humans these days, or not treating them, if you will. And we're calling it pain management rather than pain relief. We no longer have a fifth vital sign. We have our government agencies don't talk to one another. It's just total chaos, and people are suffering because of it. Jamie, again, we appreciate not only the ability to get some education out there to help people, but also let's keep up our discussions on what's wrong with this system, because we got plenty to talk about, and let's keep advocating. Again, thanks everybody, Norm, Mark, Kat and Bob, thank you for being here. You've been very educational. And again, our host, Jamie, thank you for everything. We'll sign off for this hour until next week. Good night.
Doc, before you go, before you slide away, I would like to let you know what Dr. Ibsen just said about Brandy Stokes. She's kicking some butt and taking names. She filed an injunction herself with the Maine Human Rights Council, and she's not taking no for an answer, and that's exactly what we need to do. And if Kenji, if you could jump in, I know you had your hand up. You've got about 60 seconds, brother.
No, the same issue. I saw my primary care physician tonight. He told me no increase in pain meds. I was straight up with him. I told him I am no risk, but he's not going to prescribe. So I'm not really sure. It's the schooling. I mean, this is 10 years deep, and so they're well indoctrinated, and we're up against a well-oiled machine. But we have a plan, so stay tuned.
Please stay with us. Because like you said, we have a plan
Don't give up. We're turning this thing around. Don't anybody give up.
we will win.
Well,
No giving up.
I'm not giving up.
That's
Good.
right. That's right.
I just wanted to share with you guys a few things that have helped me to be able to maintain my scripts. One is not giving up and not accepting no for an answer. Always having a man with me, which I've mentioned before, to testify to my pain and to be willing to fight on my behalf. Making sure that I and he are both dressed well, have my hair and makeup done. He wears a tie. I go only to private pharmacies, mom and pop kind of places. I go in and introduce myself with my husband. I have an entire briefcase full of my medical records, which I show to them, including my urine test screens, so that they can see that I've not done anything wrong. And I explain all of my illnesses, and I tell them I know that right now everyone is scared, and I am an
Does it do
advocate.
any good?
Yes, so far. I'm not saying that it's always going to work, but right now, I'm just trying to share with everybody a few stupid small things that may be able to help.
They're not stupid at all, Emily. They're life-saving. What you just said could very well save someone's life. So thank you. Anything you have to share, anyone has to share, we appreciate. Thank you. Having a witness with you does make a world of difference, as Dr. Tennant has said in the past. I completely agree with that.
My appeal that I have to file by January to seek judicial review of the policies of these agencies, and I'm going to be asking for injunctive relief and also nullification of any law, statute, rule, or regulation that was passed based on the 3 false premises that the CDC is perpetrating. So no attorney will touch this with a 10-foot pole, and I'm left trying to do it by myself. So that's still in the works, people.
Yeah, they're not going to own up to their lies yet.
Right. Yeah. I commend you and salute you for what you
Good
are
fight,
doing.
everybody.
Please don't give up that fight. Don't give
Keep
it up,
fighting.
please.
Yes, fight,
Yes, fight.
fight.
And Jackie just said, lots of us have no one to help us, and that is, we know that that's what weighs on our mind every day, every night. That's why we are doing all we can do as the people that we are, and we're just people, but we the people. And the last time I checked, we got to go back to any time in U.S. history that things have changed. When have things changed for the better? What did they do? Think Rosa Parks, think all the times, just think about that, and we will continue. My love is sent out to you guys. Sorry, I'm a minute over,
Evolution.
Doc. Good night. You're not alone. See you next week. Thank you so much.
God save the pain warriors.
Yes, please.
Yes.
Thank you.
Bless.
Y'all have a
God
good
bless
week.
y'all. I
God
love
bless
you all.
Love you all too.
Night,
Love you
everyone.
all.